A 25-year-old, a 25-year-old woman who is a school teacher who has a positive PPD skin test at a routine examination. She was exposed to a person with active tuberculosis when she was a child. However, all previous PPD skin tests since that time have been negative. Her last PPD skin test was 5 years ago. An X-ray of the chest shows no abnormality. Which of the following is the most appropriate next step of the management?
Ready?
Yes.
So it's treatment of latent TB. Mycobacterium TB is a slow-growing mycobacterial organism transmitted via respiratory secretions. It presents with primary latent and reactivation patterns. TB is more common and spreads more easily in crowded populations, such as nursing facility prisons. Primary disease patients have a history of subacute fever, weight loss, night sweats, cough, and malaise. Latent TB can occur as the organism proliferates within macrophages and is maintained within caseating granulomas. Purified PPD skin testing, also known as tuberculin skin testing, TST, stimulates T lymphocyte-driven type 4 hypersensitivity reaction against subdermal tuberculin antigen. Causes of false positive results include prior vaccination with BCG vaccine. Yeah. A positive result, such as this patient with no evidence of active TB, normal checks, X-ray, and sputum gram stain, is diagnostic of latent TB infection. Latent TB is treated with prolonged course of isoniazid or rifampin. The most recent guideline recommend a course of rifampicin-based monotherapy. Okay. You want me to read any of the other answer choices?
No.
Okay.
So PPD skin test positive, but chest X-ray negative. So we
Mhm.
will go for the treatment. If IGRA is positive, then still it is latent TB.
If what?
IGRA, interferon gamma release assay.
Is positive. I don't think that's late. Is it latent? I don't
Yes.
think that's late.
Sorry,
So if the interferon one is positive, is still you say it's still latent?
I think so too.
Oh,
For active TB to be called, we need uh, a tuberculin test like Mantoux test along with the chest X-ray finding, isn't it?
yes.
Or I am telling wrong.
I don't know for the eye for the interferon one though.
But
I don't.
IGRA is very popular test.
Yeah, I know, but I never I don't remember.
So keep it in your memory that we have to.
Okay. What is
Okay,
it called? Interferon
gamma release assay, IGRA. I have doubt. That's why I am asking you.
release H is right here. The development of mobile data, blah, 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 blah. Then effective in this patient means interferon such as skin test is often fast negative. It doesn't say anything about.
But
Mm,
in for latent TB, like for latent TB to be called like either IGRA or TST, like tuberculosis test, as far I remember. Okay. And can you tell me the rifamycin based therapy and its duration?
oh no. Um,
Rifamycin-based therapy, which is preferred, rifampin for 4 months, rifampin plus isoniazid for 3 months, 4-3, and rifapentin plus isoniazid, which is weekly. The rest of the previous two was daily. Rifapentin plus isoniazid weekly for 3 months. So 4-3-3 and the 9. Isoniazid monotherapy for 6 to 9 months. Now I think that isoniazid monotherapy is not given nowadays. Okay.
Here is
Next.
the IGRA thing, but I don't see any.
Like a clear cut answer, isn't it?
Yeah. Mm-mm. Let's
IGRA,
see.
look, the first line, more sensitive and specific than the tuberculin stress,
Mm-hmm.
tuberculin test.
Mm-hmm. Mm-hmm.
And it is not affected by the BCG vaccine. So it is more specific. And the word they say the latent, maybe it is
So,
for latent TB.
what do you see later? Oh, most patients with first exposed
Uh,
TB have
okay, it is
asymptomatic.
the pathophysiology. Sorry.
Oh, yeah, it doesn't
Can you
say.
can you ask in the Gemini
What do I ask? Like,
is if IGRA is positive, then is it active TB or latent TB?
IGRA is positive. Is it active or latent TB? Yes, positive is B. Yeah. Oh, no. IGRA test cannot differentiate between active and latent TB. Oh,
Okay, it cannot differentiate. That's another time.
hmm.
Okay, we need IGRA plus we need chest X-ray. If both are present, then it is active TB.
Yeah, that's why it says like if IGRA is positive, further evaluation is necessary to determine if it's active or latent.
Okay,
Yeah.
now I understand. IGRA is just equal to tuberculosis test, but more specific. That's the thing.
Okay.
Okay, a 20. Uh, It will, which of the following is the most likely cause of this patient's symptom? A 22-year-old woman comes to the a 22-year-old old woman comes to the office because of 3-year history of episodes of abdominal discomfort and frequent diarrhea during this time. During this time she also has had 4.5 kg weight loss. 2 months ago she decided to eliminate weight product from the diet, which has improved her symptoms. She has no history of serious illness, takes no medication. She appears mildly anxious. She is 5 feet 6 inch, weight is 52, BMI 19, pulse 90, respiration 16, blood pressure 102 by 50, low, slightly low. Examination, no abnormality. Which of the following is the most likely cause of this patient's symptom? Is it celiac disease?
Mm, mm. Celiac is the what
Gluten
the
enteropathy? Weight?
gluten. Okay, but yeah, probably I guess. Yeah, weight
Are
loss.
you thinking anything else?
No, abdominal discomfort, frequent diarrhea. Yeah, probably say it didn't say bloody diarrhea. Probably that.
Bloody is not for celiac, isn't it?
No, it's not.
Okay.
Mm, okay. Let's see, what is it? This one. So yeah, celiac disease, gluten sensitivity enteropathy that is mediated through immune intolerance of the protein gliadin, commonly found in wheat products. This results in, that was super easy question for. Hmm. This results in inflammatory infiltrate. Yeah, I was like, that was super like straight to the point. Inflammatory infiltration of the
That's
toxin
the
molecule,
that's another problem.
yeah, which leads to characteristic intraepithelial lymphocytosis. Okay, villus atrophy and creepy hyperplasia. Malabsorption of substances in the proximal small bowels ensures which present with symptomatic chronic diarrhea, steatorrhea, and nutritional deficiencies. Patients with celiac may develop iron deficiency anemia, which may present with decreased hematocrit and macrocytosis. Diagnosis of celiac can be confirmed by detection of anti-transglutaminase antibodies or small bowel biopsy showing villus atrophy along the intraepithelial lymphocytes. In creep hyperplasia, treatment includes avoidance of gluten-containing foods, reversal of any acquired nutritional deficiencies. Patient has 3-year history of abdominal discomfort, improved by elimination of wheat products, blah, blah, blah. It's not, how was I? Oh, laxative abuse may present with frequent bowel movement and weight loss. All the symptoms can include signs of volume depletion and dehydration, as well as hypokalemia. Identified a patient with improving abdominal after wheat products, most likely celiac. Yeah. Okay. Next.
Next, an 18-year-old woman who recently an 18 year sorry 81-year-old woman who recently immigrated from Ethiopia comes to the office because of 1 year history of knee pain. The patient does not speak the patient does not speak and is accompanied by her son, and a medical interpreter is used. 2 weeks ago she was evaluated by another provider in the practice. Results of the lab screening studies ordered at the time were positive for syphilis, TB, and hepatitis C. CT scan of the liver obtained 1 week ago was suspicious for late stage hepatocellular carcinoma. A biopsy is scheduled for next week. The patient's son asks to speak with the physician alone. The patient's son asks to speak with the physician alone. He says that he has not told the patient about the possible cancer diagnosis for cultural reasons. Which of the following is the most appropriate step in the management?
Ready?
Yes.
Is ask the patient how much she desires to know about her medical condition. Physicians should deliver bad news in a thoughtful and patient-centered manner. Prior to delivering bad news, physicians should first attempt to clarify patients' preferences for delivery of the news. These questions should inquire about how much and what type of information a patient desires to hear. Information about a poor prognosis commonly challenges a patient's life, and some patients may prefer not to know all of the details of the prognosis. Physicians should deliver news according to the patient preference. This patient-centered approach honors patient autonomy. It is not trick the patient latent syphilis will be irrelevant. The patient late stage hepatocellular carcinoma is most life limiting diagnosis and should be addressed first. The physician should first assess the patient preference around information delivery to determine how to discuss her late stage cancer. Next.
An asymptomatic 37-year-old man with alcohol use disorder 37-year-old man with alcohol use disorder comes for an initial comes for an initial examination. He drinks approximately 12 cans of beer. Examination shows primary erythema and multiple spider angiomata of the upper back and chest. The spleen is palpated 3 cm below the left costal margin. Abdominal examination shows shifting dullness. Despite physician's strong recommendation for the patient to stop drinking alcohol, he says he has no intention of abstaining. Which of the following is the most appropriate immunization for this patient?
Between, I don't know. So, is that one of the Shin version? Oh,
Yes, chronic liver, like features of cirrhosis, isn't it? Like features of
yeah,
chronic liver disease, stigmata of
yeah,
the chronic liver
yeah.
disease.
Mm-hmm.
So, and in CLD, there is splenomegaly. So, is it Shin? Strepto- If it is Shin,
The fishing, it can be three. There is three options here, so it doesn't. It's not helping. The fact that we know that is Shin, it doesn't help it here. Uh,
uh, al- she and not sexually active. I want to rule out. I want to rule out the meningococcus.
meningococcus probably, yeah, we can rule it out because it's not. Yesterday we read he was in high school, at the end of high
Yes,
school, and then he lives in a place that's crowded. So it's not that.
either
Then
Haemophilus or
on pneumococcal.
pneumococcal.
Pneumococcal, the 23 was, I don't know. I remember it was all people, but I feel like he had other options too.
Haemophilus
Yeah,
influenza type B conjugated. Is it what does the conjugated mean?
I don't know. I know we read all of that yesterday. It was because that question was
Huh,
explaining everything. But I don't remember.
feeling sad.
Okay, okay. Let's see. Ready?
Yes, pneumococcal.
It is
You
pneumococcal.
choose B, isn't it?
Yeah, but at least we knew it was between those two. That's already closer than yesterday. Pneumococcal, it was yesterday. It was that we were wrong, completely wrong. Pneumococcal vaccine available as the 1315 conjugate vaccine or the 23 polysaccharide vaccine. Protects against strep pneumo. The conjugate vaccine, so the 13 and 15, typically given as 4 doses, 2 for 6 months and be like 1 year. The CDC recommends routine vaccination for protection against pneumococcal disease in infant children and adults over 65 years old. Pneumococcal disease is responsible for a large burden of mortality, and large scale of vaccination programs have been effected. Yeah. It recommended that this patient receive pneumococcal 23 vaccine, the PPSV 23, at this time because of his history of cirrhosis, which increases his risk for developing pneumococcal disease. Adults over 65 years old who do not have an immunocompromising condition, including cirrhosis, CSF fluid leak, or cochlear implant should receive 1 dose of the PPSV 23. Any patient who received the PPSV 23 prior to turning 65 years should receive a single additional dose after 65 years and at least 5 years after the prior dose. So you give it to kids, and then you give it to adults over 65, and then you give it to people under 65 that have some kind of chronic thing. It's not hemophilus type B conjugate vaccine is not indicated for this patient. Hemophilus is a gram-negative bacterium that can result in various conjunctivitis, otitis media, bronchitis, pneumonia. As clinic patients are at risk for infection with encapsulated bacteria. Vaccination against encapsulated subtypes hemophilia is indicated. Cirrhosis does not confer additional risk for infection with hemophilus. Okay. And it's not the meningococcal protects against Neisseria, which may lead to life-threatening sepsis, meningitis. Meningococcal vaccine is available as conjugate vaccine and a recombinant protein serogroup B vaccine. The conjugate vaccine is indicated for all children and is administered in two doses in between 11 to 12 years old and again at 16 years old. The serogroup B is given as an additional dose, usually between 16 to 18. Certain adult patients are particular risk for meningococcal disease, such as patients with HIV infection or men who have sex with men benefit from an additional dose of meningococcal every 2 to 3 years throughout their life. Okay.
Okay.
Oof. Okay. So
66. Sorry.
sorry. So I was going to say so pneumococcal if they have any chronic disease, meningococcal.
Pneumococcal, that that line is very interesting. Like pneumococcal do not immunocompromise. Those who are not immunocompromised, including cirrhosis, only one shot above 65. You you have seen?
Those who are not
Yes,
immunocompromised.
who are not immunocompromised. That means cirrhosis is not an immunocompromised situation.
Oh, I get what you're
I
saying.
am very astonished with this word. Immunocirrhosis patient is very vulnerable than the lots of the immunocompromised person.
But this patient is 37, so he don't even fall on that 65-year thingy.
Yes,
Um, okay.
but for pneumococcal there is like four dose, 2, 4, 6, and 1 year. But for above 65, only one. And
Only one. And
yes,
you can also give below 65 because this
yes,
patient is 37. But I guess they have to have a chronic disease.
but below 65 too. Like uh, below 65 should receive one single additional dose after 65 years and at least 5 years after the prior dose. Like two dose, isn't it? I don't
I don't
understand the
know.
last line. Any patients who receive the this one in,
Mm-hmm.
so what, any patient who received PPSB to the turning age 65 should
Mm-hmm.
receive a single additional dose after 65
Mm-hmm.
and at least 5 years after the prior dose.
Mm-hmm.
Like if he got PPSV vaccine at the age of 60, then after 5 years, he should uh, be given another PPSV, like two dose.
Yeah. So he receives it at whatever 37 right now because he has cirrhosis. And then after 65, you have to give them another dose. And
It,
then every
it is it is for every patient, not for cirrhosis. Any patient, they have told.
No, I don't think that's what they were saying. No.
Like look at the last line. Any patient who receive.
No, but why would they receive it? I think they were trying to say if the patient has a chronic thing and you give him before 65 because of the chronic thing, you
Okay.
have to give it again. I think that's what they were trying to say.
Okay. Another query.
Hmm.
If a person got all the four vaccines,
Then what?
then we need to give pneumococcal vaccine. Like if
Mm,
he become immunocompromised or like if if his spleen is removed, then we need the vaccine again.
yes, if he has some kind of I'm thinking some kind of chronic disease like CKD or something, you have to give him now the PP, the 23. You have to give them the 23. But if they are less than 65, you give them the 23 at that time because they have CKD. But then when they turn 65, you give them again the one dose of the 23 again at 65. I think that's what they meant.
Okay.
Um,
Even if he completed the full schedule,
Even if you already completed for the 4 6, the two
two,
four
four,
six,
6, and 1 year. Okay.
you give them because they have CKD.
Immunocompromised state.
Mm-hmm.
Okay. Okay. I got it.
Yeah.
Too
Okay,
much
so
discussion.
no, but it's good because these vaccine things they're gonna
Yes.
come. It's
We,
good.
we can't remember. We can, what we just remember is the consultation.
The,
Okay. Okay. When I start reading the vaccine, I feel feverish.
yeah, me too. Because I'm always like it's never like straightforward.
Okay. Uh, which of the following screening test is most appropriate at this time? A 66-year-old woman comes to the office. A 66-year-old woman comes to the office for a routine health maintenance examination. Her last menstrual period was 10 years ago. She has no history of serious illness and takes no medication. She has no history of serious illness, takes no medication 5 years ago. A routine pap smear show no abnormalities. Human papilloma virus testing was negative. A mammogram obtained 1 year ago showed no abnormality. A colonoscopy done 8 years ago showed no abnormality. She does not smoke cigarette. She has been she has been in monogamous relationship for the past 40 years. Vital signs are within normal. Vital signs are within normal limits and physical examination shows no abnormality. Which of the following screening test is most likely appropriate at this time?
Ready?
Yes. Is it DEXA?
That's what I picked.
Okay.
Yeah, it's osteoporosis is a metabolic bone disease characterized by diffuse low bone density. Evaluation of osteoporosis involves a DEXA scan and is defined as bone mineral density less than 2.5 standard deviations compared to young normal population. T score. The USPST recommends a grade B level. Huh? At the gravy level to screen women over 65 for osteoporosis and under age of 65 when increased risk factors exist. The most common risk factor for development of osteoporosis is age, smoking, chronic inflammatory disease, steroid use, and estrogen depleting conditions in women. Osteoporosis is often asymptomatic but increases the risk for fractures, most common involving the hip vertebra and distal radius. Calcium and vitamin D supplementation are recommended for treatment and prevention of osteoporosis. Recommendations should be made for weight bearing exercise in the absence of other contraindications to slow deterioration of bone mineral density. But bisphosphonates inhibit osteoclast activity and can be used to treat osteoporosis to reduce further loss of bone mineral density. For D66, yeah, it is not. What was I confused about? I think D. What is D? Test for October is not required for this patient who had normal 8 years ago colonoscopy, as the colonoscopy is every 10 years. Testing for occult blood may be performed yearly for individuals undergoing flexible sigmoid colonoscopy. Oh, flexible sigmoidoscopy. Okay, next.
Okay.
Wait, that's 25, 26. Okay.
And the patient returns to the office 2 weeks later to discuss the results of the screening test. She has started calcium and vitamin D supplement. Results of the DEXA scan show a lumbar spine T score minus 2.8. Serum lipid studies show total cholesterol concentration 230 milligram per deciliter and HDL concentration show 60 milligram per deciliter. Her estimated 10 years atherosclerotic cardiovascular risk is 5.7. Which of the following is the most appropriate next step?
Hmm.
Is it bisphosphonate?
Probably, because I don't. Why will it be? I
Because
thought
T
that
score is below 2.5, isn't it?
T score is below 2.5. Yeah.
Like, yes.
What was the 10-year Ateroka? What was it? What was the limit
10
for
year,
that?
7.5, more than 7.5 to 10. 10 year,
1.5.
that one, primary prevention.
Okay, then it's probably, yeah, bisphosphonate.
LDL more than 190, age more than 40 with diabetes,
Yeah.
and ASCVD more than 7.5 to 10. Okay,
1.5. Okay. So yeah, it's, oh, where am I? Never mind. Okay, they don't have the answer for 26.
I think that
'Cause-
it is right.
yeah, it's probably right. They don't, I mean, I can
If
copy and,
it was possible, then
oh,
not possible.
never mind. I cannot copy. Let me see.
You
Maybe.
can copy.
I trying. Let me see. Yeah, copy.
Wow, I can't. Okay, we
You
need the
can.
answer. Now, no, I can't.
It doesn't even let me paste. I copied it, but it doesn't let me paste it.
Like you have somewhere paste somewhere else and then you start paste here.
Because it
Like,
says here I let me copy.
okay,
And then here control, is it paste? I don't know. Nope, doesn't let me paste. Never mind. I don't know. Oh, right here. No, but it's not pasting what I just copied.
you can't. I think so.
No, it doesn't let me do it.
But you can copy. It's it's visible that you can copy.
But you see when I do
You
this
copy first. Okay. Then
copy,
then paste fast in the any other like any
like
other
Google
site any other like Wattpad or anything else.
paste. No, it's not pasting.
Okay. So
Mm, I don't get it. Can you do it on your side? Is it letting you?
no,
No?
because it's a picture. That's why I can copy. But in here
Oh,
you can copy. That is very interesting. You have like Wattpad or anything else,
no.
like you write somewhere, like Windows. Uh, what can I say? You have something like Microsoft Word.
Oh, no, I didn't pay. They had to pay for this one. I didn't
Oh,
pay.
sorry.
I'm
No,
not
no.
going to.
Everything in my computer is breakable.
That's so
Like
weird.
my Windows is not a paid version, but I
Oh,
can
no, no.
use everything.
No, for me, everything you have to pay for. I don't know if it's Apple that does that because I used to
Yes,
have Windows and
yes.
I didn't have that.
Windows have, as you are stays in the US, that's why everything you have to pay.
No. Oh, no, it's not very. But I think we got
You
it.
are making the ROC card.
I don't, but I don't understand. But I think we got it right though because it makes sense
Okay,
that is
don't go to the Gemini.
Gemini. Okay.
Okay, click the this like microphone portion and read the question.
Okay. Let me try.
Allow?
Uh,
Yes. Now read the question.
The
You can read.
patient
Yes, you can read it from here.
the patient returns to the office 2 weeks later to discuss the results of her screening test. She has started calcium and vitamin D supplementation. Is it writing? Okay. Results of the DEXA scan show a lumbar spine T score of negative 2.8. Serum lipid studies show a total cholesterol concentration of 230 milligrams per deciliter and HDL cholesterol concentration of 60 milligrams per deciliter. Her estimated 10-year atherosclerotic cardiovascular disease risk is 5.7%. Which of the following is the most appropriate next step in treatment? I need to read. Oh, that's it.
Don't say anything. Just go there and delete the I need to wait. Then it will automatic. Okay. Yes. Now press the enter button. Like the that button. Yes. So when you okay, let's see the answer.
But it didn't give them the answer choices, so how do they know?
They will give the answer choice. The most appropriate statement is a pharmacological osteoporosis is the bisphosphonate. Common first line.
What do you what is what do
Yes.
you leave?
The
Oh,
common
okay.
first line. Yes. If you give the answer choice, they will give you the answer choice.
Um yeah, it's
So
Alendo because you see here they even say start the statin and they said this is less urgent.
yes,
Hmm. Yeah, we got
medication
it.
of osteoporosis. So you can don't need to write the answer. Just do it
Mhm.
in this way. You got my point. If you
Yeah.
don't, if you don't know any answer, just do it this way. I talk to the Gemini all the time. That's why I know
No,
these type of things.
don't put it there many all the time.
No,
Okay.
no, no. It is very helpful, truly.
Oh, computer about to die. Wait, let me get my my charger before it turns
Okay,
out.
okay. Go, run.
This patient, what does he have? This patient with dyspnea exertion on exertion of topnia, bacillus crackers, S3 sound presentation consistent with heart failure with reduced ejection fraction. Patients with decompensated heart failure may additionally present with jugular venous distension and peripheral edema on physical exam. Checks X-ray may show pulmonary edema, cardiomegaly. Lab studies often show an increased BNP concentration. Echo is the gold standard for diagnosis. It may show either reduced ejection fraction or preserved ejection fraction with diastolic heart failure. There are numerous causes of heart failure, including ischemic heart disease, hypertension, valvulopathy, pulmonary disease, infection, arrhythmia, congenital cause. Treatment of heart failure involves management of underlying causes and associated conditions, as well as appropriate drug to improve symptoms, preserve myocardial function, and reduce mortality. Initial guideline recommended therapy is a combination of beta blocker, renin-angiotensin aldosterone system inhibitor, and diuretic. ACE inhibitors, as well as beta blockers, aldosterone receptor blockers, ARBs, and mineralocorticoid receptors antagonists have been shown to reduce mortality in patients with heart failure. It's not digitalis. Digoxin is used for symptomatic relief in systolic heart failure as it improves cardiac myocyte contractility through inhibition of the sodium ATPase. While it improves symptoms of heart failure, it has not been shown to decrease mortality. Diuretic therapy reduces preload and provides symptomatic relief in patients with heart failure. However, no survival thing. And nitrates can be used in select patients as second line therapy for heart failure in patients who are unable to tolerate ACE or ARB. Secondary therapy with both hydralazine and a nitrate is recommended. Okay, next.
Can you tell me the drugs which in heart failure with preserved ejection fraction? There are some drugs which which is used, and actually it reduces hospitalization and possibly mortality benefit is given.
Heart failure with, you say, reduced ejection fraction.
Preserve ejection fraction.
Preserved ejection fraction. Isn't it this one's the ACE and the
One
ARBs,
is ACE, yes.
the
Another,
ARBs,
sorry,
ARB, sorry,
ARBs are like ARBs.
yeah.
Okay, AC and
And
ARB are similar. Okay, and
you
other drugs.
you said
There,
we reduce, we preserve. You said we preserve ejection fraction. Um,
yes, in preserved ejection fraction, there are some other drugs that can be used, like SGLT2 inhibitor.
mm,
SGLT2 inhibitor, like this is an anti-diabetic drug, but it has
mhm,
possible mortality benefit, and it can be added in case of heart failure with preserved ejection fraction.
we
And
preserve
MRA can be used, like
the
spironolactone,
the
mineralocorticoid antagonist. And if you find like if there is volume overload, you can use
mm,
loop diuretics, but loop diuretics does not have any mortality benefit. Okay.
okay.
And there are another drug, ARNI. What is ARNI?
Oh no. Well,
Angiotensin receptor neprilysin inhibitor, ARNI.
oh, the nepralizing.
That
Yeah.
that that one also has the mortality benefit. Sacubitril valsartan.
Okay.
Okay.
Mention to increase. Oh, go ahead. You're the one that reads.
Mm. A 65-year-old man comes to the office because of five. A 65-year-old man comes to the office because of 5-year history of worsening 5-year history of worsening constipation. During this time, his stools have been hard, and his stools have been hard and have decreased in frequency. He reports often having to strain and a sensation of incomplete evacuation following bowel movement. This is the first time she has he has sought treatment. Colonoscopy 5 years ago showed no abnormality. He has a history of hypertension for which he takes hydrochlorothiazide vital signs are within normal limit. Physical examination discloses a palpable colon. Physical examination discloses a palpable colon with hard stool over the left of the abdomen. The remainder of the physical examination shows no abnormality. Results of the lab studies are within reference age. In addition to increasing fluid intake, which of the following is the most appropriate initial pharmacotherapy?
Mm, ready?
Okay.
So it's cilium. Constipation is a common condition that can develop idiopathic or secondary to many different causes, including metabolic derangement, medication of adverse effects, hypothyroidism, spinal cord injury, pregnancy. Initial management of idiopathic constipation includes patient education, dietary changes such as increased water and fiber intake, as well as bulking or non-bulking laxatives. Cilium is an example of bulk forming laxative that helps to increase stool frequency as well as soften the stool as a result of its fiber content. If increased fiber does not control the constipation, many other stool medications are available, such as Senna, PEGs, polyethylene glycol, lactulose, doxate, and magnesium citrate. For this patient, seeking first-time treatment who does not have a clear secondary cause of celium is the most appropriate. It is not linaclotide. I don't even know what is that. Medication used to treat is a medication used to treat chronic constipation and irritable bowel syndrome. The narcotype functions by increasing intestinal secretions through the induction of CG, huh? cyclic guanosine monophosphate, which results in increased chloride and bicarb and thus higher fluid content in the intestinal lumen. In this case of previously untreated presumed idiopathic constipation, the most appropriate initial thing is psyllium. It's not lubiprostone medication to treat chronic constipation and irritable bowel syndrome also. Miprostone functions by activating a chloride channel along the intestine to increase intestinal fluid secretion. The most appropriate initial blah 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 blah. And it's not magnesium citrate, it's an osmotic laxative. Magnesium citrate functions by increasing the intraluminal water content, causing colonic distension and resultant colonic peristalsis. Magnesium citrate can be can be a reasonable option for the cases of constipation, but is only recommended for occasional use. Okay.
Can you tell me the side effect of Senna? There is a unique and popular side effect of Senna.
Sena, Sena.
You have
Mm.
read. If I say, then you will. Melanosis coli.
Oh, yeah. Yep.
This is a
Yep.
popular side effect.
Yep.
Okay. Am I interrupting a lot?
No.
Okay. If you feel that, say it. Okay.
No.
I got this question wrong. I thought
Okay.
it's lactose. Okay.
Oh, this one.
A 65-year-old man comes to the physician to request prostate cancer screening. He has not had prostate cancer screening. When I see the prostate cancer, I think about he has not had urinary symptoms. He has no history of serious illness and takes no medication. His father had a prostate cancer at the age of 85. Examination of the patient shows no abnormality. Which of the following is the most appropriate next step regarding prostate cancer screening for this person?
Hmm. 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 In between discussing, and it's not indicated at this time.
When we give the when we start prostate cancer screening,
I don't think that we. I think
he
is
has a family history.
he has. I don't think it's when you have a family history. I think is there was. I feel like it's not indicated, but discussing the risk and benefits and yeah, maybe
Maybe
next.
you are right.
Okay, ready?
Yes.
Discussing, yeah. It's not there's no specific time. It's just when the patient come and if they discuss it with the doctor and the doctor decides, okay, fine, we'll do it or not. But it's not like a specific time from what I had read. So the
Okay.
most appropriate next step for this patient is discussing the risks and benefits of prostate cancer screening options and allowing the patient to decide. Prostate cancer is the second most common cancer in men, most commonly asymptomatic but can present with urinary symptoms such as hesitancy, hematuria, or bone pain if metastatic. These factors for its development include advancing age, certain ethnicity, geographic location, family history of prostate cancer, certain genetic factors such as BRCA and Lynch syndrome, while screening patients over 55 years of age with measurement, while screening patients over 55 years with measurement of PSA concentration may decrease the risk of death from prostate cancer. There are significant risks and harms associated with screening, such as false positive test results that lead to additional testing or the need for biopsy. As many prostate cancer remain indolent and do not become clinically significant prior to patient's death. Even appropriate diagnosis of prostate cancer with a screening test can be associated with harms such as those associated with surgical resection and chemoradiotherapy. As such, the USPSTF recommends that the decision to screen for prostate cancer between 55 and 69 years be an individual decision made by patient based on their health values after engaging in shared decision making with the physician. Uh, USPST does not recommend screening for patients over 70.
So above 70, we have to do the screening.
Does not recommend. Does not.
Over 70. Oh, sorry, sorry.
Okay. And it's not E. Where is it? Prostate cancer screening is
Like
not
if
in.
patient wants, then we can do the screening. If patient do not want, in the at the age of 55 to 69, we should not go for screening.
Yeah. Mm-hmm.
Very
Prostate cancer is.
abstract.
It's not indicated for this patient is incorrect. The decision to screen for prostate cancer is an individual one and should be made by patient based on their goals and values after discussing the risk and benefit with the provider. If this patient desires prostate cancer screening, then it would be inappropriate to deny it to him. Okay. So 55 to, I guess,
69.
69. Hmm, interesting. Okay, next.
A 55-year-old man comes to the a 55-year-old man comes to the office for a routine examination. 18 months ago, he has progressive difficulty. 18 months ago, he has progressive difficulty and seeing small things. Progressive difficulty and seeing small things. His symptoms initially improved with the use of weak reading glasses. He then required stronger reading glasses. He then required stronger reading glasses. He reports no other current problems with his vision and is otherwise asymptomatic. He has hypertension treated with hydrochlorothiazide. Vital signs are within normal limit. Visual acuity is 20 by 30 in the left eye, 20 by 20 in the right eye. No other abnormalities are noted. Which of the following is the most appropriate next step in the management? Hmm.
Hmm.
Is it praised by QCs?
Okay. Mm,
Like, is it due to age?
right, probably. So I'm like between
Because
referrals or
no, he has hypertension treated with hydrochlorothiazide, but hypertensive retinopathy does not go with this progressive difficulty reading, isn't it?
yeah.
Difficulty seeing
So
small things.
do we refer him to ophthalmology or no further management?
I am thinking glaucoma is progressive vision loss, sudden severe vision loss, isn't it?
Yeah, it's not glaucoma.
I think
Mm,
that no management. It is praised by QCs. I think so. Sorry, presbyopia.
yeah,
Presbycusis for AR.
super. Okay, so I guess no further management. Let's see.
Oof. Yes.
Yeah, this middle-aged patient who presents with progressive
I'm
difficulty
talking
with
about eye, but I'm telling you about AR.
yeah.
Okay.
Progressive difficulty with near vision somewhat improved with weak reading glasses, slightly experiencing presbyopia and age-related loss of the eye's accommodative ability. Accommodation describes the ability of the eye to alter, increase its refractive power in order to focus on near visual targets. The MLOT theory of accommodation holds that contraction of the ciliary muscles relaxes tension of the zonular fibers upon the crystalline lens, allowing the lens to become rounder. thereby increasing the curvature of his anterior surface and increasing its dioptic power, allowing for focusing on objects at close distance. The accommodative ability of the lens is dependent upon its ability to distend its shape. Presbyopia is a normal age-related change. Patients present with blurry vision are near distance and notice that object must be held at farther working distances to be seen clearly. Normal pupillary reflexes to accommodation are not affected. Um, by presbyopia, treatment is with reading glasses with positive dioptric power. This patient is currently maintaining good visual acuity and is doing well with stronger reading glasses, so no further management. And it's not C. Referral to ophthalmology is not necessary at this time. This patient is seeing well with reading glasses and maintaining good visual acuity. A referral to ophthalmology may be needed if the patient was unhappy with his vision or if his visual acuity was below 240, at which an evaluation for cataracts, refractive, blah, 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 will be warranted. So more than 240. Okay. Mm, next, or you want to take like a 5 minute break?
No, next.
Okay.
No 5 minute break.
No, I'm sorry. I was you texted me. I was gonna do 5 minutes, but then my brother is like,
Okay, okay. You wanna take break?
no, no, it's okay, it's
Oh
okay, it's
yeah. Oh, sorry. I am being very rude. Okay.
okay.
Have increased shortness of breath for 6 months. He has lost 1.4 kg in the last 3 months, and his appetite has not decreased. He has a non-productive cough for more than 40 years. He has smoked 2 packs of cigarette for 50 years and worked from age 30 to 40 years in a factory making automobile brake linings. He is afebrile and not cyanotic. There is dullness to the percussion. There is dullness to the percussion and auscultation, diminished breath sound, and egophony over the right chest. Unnoted X-ray of the chest shows a right pleural effusion and a mass contiguous with the pleura in the right lateral chest. There is irregular linear opacities that are most dense in the lower lung fields. Which of the following is the most likely diagnosis?
Ready?
Wait 1 second.
Mhm.
Okay.
Okay, so it is asbestosis, a type of pneumoconiosis that results from inhalation of asbestos fibers, leading to progressive inflammation and fibrosis of the alveolar and pulmonary interstitium. Patients may be asymptomatic or may develop chronic pulmonary disease characterized by chronic cough dyspnea associated with progressive pulmonary fibrosis. Occupational exposure is the greatest risk factor for developing asbestosis. Occupations with risk for asbestos exposure is good plumbers, pipe lifters, steam fitters, electricians, insulation workers, carpenters, general labor, boil makers, welders, coders, janitors. Physical exam may
Automobile
discuss
brake
common.
lining means like boil makers. Like which of the occupation? Is this because the asbestos is because he is working in a factory of automobile brake lining, isn't it?
Yeah. Mhm. Physical exam may discuss pulmonary crackles, digital clubbing, and signs of pulmonary hypertension and right ventricular hypertrophy, such as parasternal eve, low P2, wide split S2. Characteristic imaging findings may include bilateral infiltrates with lower lung predominance, calcified pleural plaques, and rounded atelectasis. Pleural effusion may be present. It's not anthracosis. Type of pneumoconiosis caused by inhalation of coal dust, cold. which can lead to accumulation of carbonaceous material in the lungs, commonly affects coal miners, industrial workers, and individuals exposed to environmental pollutants. Symptoms are often non-specific, like cough, dyspnea, chest pain, can progress to bronchitis, emphysema, or progressive massive fibrosis. Results of imaging typically show diffuse bilateral infiltrates with coal particles, which can lead to pulmonary fibrosis, impaired lung function. It's not berylliosis. Exposure is more common in patients with history of working in aerospace or nuclear engineering fields. Berylliosis. It presents as a non-caseating granulomatous disease with lymphadenopathy that resembles sarcoidosis, giving this patient pleural involvement and lack of blah, blah, blah. Okay, it's not byssinosis. Don't know what that is. Type of occupational lung disease caused by inhalation of cotton, flax, or hemp dust. Workers in textile factories and cotton processing plants are at increased risk for developing this condition. Symptoms typically present as episodic respiratory distress, coughing, and wheezing during or shortly after exposure to the dust. Results of imaging study can include diffuse interstitial infiltrates and bronchial wall thickening. And pulmonary function test may show obstructive or restrictive. It is not silicosis form of occupational lung disease caused by exposure to silica dust. Patients typically present with dyspnea and productive cough with characteristic perihilar and upper lobe predominant opacities. Uh, no pleural involvement. Okay,
Okay.
next.
One last thing.
Hope for the best. Oh,
Yes, because you nowadays you are unable to sleep. I'm
I'm,
thinking about this.
my
You
anxiety is gonna go. I was already anxious. Now my anxiety is gonna go even up. It's just, oh God.
when the closer people fall in danger, then we actually starts feeling that what is going in the world.
Mm-hmm. Mm-hmm.
Okay, okay, okay. Inshallah, your brother will be safe. Inshallah. Okay. A 52-year-old Egyptian woman comes to the office with adult daughter because of 5-day history of headache. The patient is visiting her daughter in the United States for 3 months and does not speak much English. The daughter offers to translate for her mother and reports that the patient has a history of hypertension. She says that the patient's medications are amlodipine, lisinopril, hydrochlorothiazide, and further explains that the patient ran out of medication 2 weeks ago. Blood pressure 175 by 105. Remaining vital signs are within normal limit. Physical examination shows no abnormality. Which of the following is the most appropriate next step in the management?
Ready? Yeah.
Speak. Sorry.
Oh, I can hear you. You say yes.
Yes.
So it's arranged for telephone interpreter services. Arranging for telephone or in-person interpreter services should be the physician first step. Professional interpreters can provide high quality translations that maintain patient safety. Credentialized interpreters are trained in medical knowledge and vocabulary, ethics, and cultural sensitivity. Relying on a family member for interpreting increases the risk of miscommunication about medical or culturally relevant details and can jeopardize informed consent for treatment and patient safety. This is important for all care, but particularly so in this case, as miscommunication to the patient's daughter could lead to blood pressure mismanagement and hypertensive urgency. It's not, I will see. Obtain ECG and refill the patient prescription and schedule a follow-up exam in 2 days before speaking with patient will not be appropriate. The physician should first gather a history of present illness and explain the plan. Therefore, the most appropriate step is to arrange interpreter services to facilitate communication with the patient. Send the patient to the ED for further evaluation is not clinically indicated. This patient lacks signs of hypertensive urgency and emergency. Oh, regardless of the care setting, the physician should directly communicate with the patient to an interpreter. Okay, I thought she had urgency, but I guess no.
Okay.
Okay, next.
Which of the following is the most appropriate additional history to obtain from the patient? A 35-year-old man comes to the physician because of 3-month history of fatigue, increased sleepiness, and feeling that he cannot enjoy usual activities. 3-month history of fatigue, increased sleepiness, feeling that he cannot enjoy the usual activities. During this time, he has decreased appetite, resulting in weight loss. He has no history of serious illness, no prescribed medication. 3 weeks ago, he was fired from the job because of decreased productivity. He describes his marriage as good, but says there have been recent marital strains because of financial concern. Which of the following is the most appropriate additional history to obtain from the patient?
Between B and alcohol and over-the-counter medications, not prescribed medications. I guess I'll go with alcohol. Ready?
Yes, it is MDD, isn't it?
I yeah, I guess. I mean, I guess you have to check for MDD. I don't. Yeah, I guess. A throat substance use history is needed in patients who are experiencing psychological distress in the setting of, or example, in the setting of a stressor, or who carry psych diagnosis, as substance use is commonly comorbid in these patients. Okay. Patients may cope with stress by using internal or external strategies, which may be adaptive or maladaptive. An example of an adaptive internal coping strategy is cognitive reframing or viewing the situation in a different way. An example of maladaptive external coping strategy is using substances to numb or avoid emotion. This patient is experiencing distress and demonstrates fatigue, anhedonia, and decreased appetite in the setting of a stressor, meeting criteria for adjustment disorder. Adjustment disorder refers to onset of an emotional disturbance within 3 months of an identified stressor. What is the stressor? I don't know.
The
As such,
loss
what
of
is
the uh,
what?
job.
But he lost his job 3 weeks ago, but the thing started 3 months ago.
The adjustment disorder within 3 months, isn't it?
But he lost his job 3 weeks ago. But he started feeling fatigue 3 months ago. So he
Okay.
started all these symptoms before he lost his job.
Job, yes.
That's why I'm like, what is the okay? As such, the patient should screen him for, the physician should screen him for alcohol or drug use disorder. The treatment of adjustment disorder commonly includes grief supported psychotherapy. It is not E. What is E? Whether the patient takes over the counter medication is an important history question for general medical patients. This question is especially important for patients taking prescribed medications that may interact with over the counter medication. However, given the increased comorbidity between psych and substance use disorder, gathering substance use history is more pressing in the case of this patient. Okay,
Not that
next.
convincing question.
Not, yeah, not really.
Which of the following is the most appropriate prophylaxis for this patient? A 48-year-old woman with mitral valve prolapse and mild MR comes to the physician for a follow-up examination at her last visit. At her last visit 12 weeks ago, the pulse was 76 per minute, blood pressure 138 by 82. She says she feels well. 8 months ago, she began low sodium diet. Exercise program decreased the blood pressure. She takes no medication. She is allergic to penicillin. Her pulse is 72 per minute, blood pressure 124 by 76 on cardiac examination 2 by 6. Diastolic murmur, heart at the apex. The remainder of the examination shows no abnormality. In a week, she will go dental cleaning. Which of the following is the most appropriate prophylaxis?
Mm, ready?
Yes,
Okay, so is no prophylaxis required. Endocarditis prophylaxis is recommended for patients with high-risk cardiac feature in undergoing procedures that put them at increased risk for development of bacterial endocarditis. These cardiac features include prosthetic heart valves, prior infective endocarditis, unrepaired congenital cyanotic heart disease, or repaired disease with residual shunts or valvular regurgitation near prosthetic material. Repair congenital defects with catheter based intervention for the first 6 months after the procedure, and valvular regurgitation in a heart transplant recipient. Jesus. High risk procedures include dental procedures with gingival manipulation of perforation of the oral mucosa, respiration tract procedures in which the mucosa is violated, procedures on infected soft tissue, and cardiac surgery with prosthetic material. Okay, so let me repeat it again. These cardiac features include the prosthetic heart valves, prior infective endocarditis, unrepaired congenital cyanotic heart disease, or repair one with residual issues like valvular regurgitation and whatever. Repair congenital defects with catheter based intervention in the first 6 months after the procedure. Valvular regurgitation in a so basically somebody with a heart transplant has a problem. Okay, okay, next.
next. A 24-year-old A 24-year-old woman, gravida 1, para 1, comes to the office because of 1 day history of moderate right lower abdominal pain and vaginal bleeding 1 year ago. Her uncomplicated pregnancy ended in a spontaneous vaginal delivery of a healthy newborn term. Her menstrual cycle was 7 weeks ago. Previously, mens occur at regular 28 days interval. 5 years ago, she had pelvic inflammatory disease, which resolved with cefotoxin and doxycycline therapy. She has smoked 1 pack of cigarette daily for 7 years. 7 years, 4 days ago, she began varenicline therapy. She takes no other medication prior to the pregnancy. She uses copper iodine. Her current she currently uses no contraception. She is 163 centimeter tall, weight is 66 kg, BMI 25 kg per meter square. Her temperature is 37.2, pulse is 88 per minute, respiration 16 per minute, blood pressure 114 by 76. Abdominal examination shows tenderness to palpation of the right lower quadrant. There are no palpable masses. LV examination shows a closed cervical os. There is no blood or discharge. There is mild cervical motion tenderness. Knowing adnexal masses are palpated. A urine pregnancy test is positive. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Yes.
Okay, so this is one of those questions that take time on the exam for no reason. We just needed to know the last sentence. Urine pregnancy test is positive. What is the next step? We didn't need to read all of the question. But I'm
Hmm.
like, this just took you. It's gonna take us like I don't know how many minutes on to read, but we just needed the last sentence. Anyway, pregnancy is suspected when there is a miss or delay period. Menstrual period. Ectopic pregnancy is an abnormal pregnancy in which the fertilized ovum implants in the fallopian tubes on the ovary within the peritoneal cavity. A history of PID is an important risk factor. Ectopic pregnancy often presents with vaginal bleeding and abdominopelvic pain. Beta HCG would be increased, leading to positive urine serum pregnancy tests. Ectopic pregnancy are non-viable. Diagnosis can be confirmed with transvaginal ultrasound, which will fail to show intrauterine gestational site. Transvaginal ultrasound is more appropriate next step for patient. Ectopic pregnancy can be managed medically using methotrexate for small early pregnancies, but may require salpingectomy or evacuation with laparoscopy for larger pregnancies. In cases of medical treatment failure, in cases of complication, one complication of unrecognized ectopic pregnancy is rupture, leading to bleeding and hemoperitoneum. In this case, physical exam may show abdominal guarding. Severe cases may lead to hemorrhagic shock with tachycardia, hypotension, anemia. Treatment of a rupture ectopic pregnancy is exploratory laparotomy. Okay, next.
Which of the following is the lab finding likely to be noted in this patient? 36-year-old man is brought to the office. Running partner. He's brought to the office. 36-year-old man brought to the office by his running partner after he completed 26.2 miles marathon. Shortly after the race, the patient reported nausea and moderate headache. He also had difficulty maintaining the balance and was oriented to the person but not the place and the time. His running partner reports that the patient drank a lot of fluid during the race because the ambient temperature the race was 94.94 degree Fahrenheit. The patient has no history of serious illness, takes no medication. He appears pale and diaphoretic. He is oriented to day and time but not the place. Temperature normal, pulse 90, respiration 16 per minute, blood pressure 141/84. Which of examination showed no other abnormality? Which of the following lab findings would most likely noted in this patient?
Hmm.
Drank.
I think my phone, I don't
In the
know. This
marathon, we should not drink lots of fluid. We need to take Gatorade, this kind of.
get what- yes. Ready?
Yes.
Uh, Hyponatremia. Whatever. Hyponatremia has many causes, included but not limited to excessive fluid intake, diuretic use, adrenal insufficiency, heart failure, kidney disease. In this case, while running a marathon and sweating profusely, he replenished his fluid with free water only, which is hypotonic to the sweat that was lost. Because of this, the patient had a progressive and relative rapid decline in his overall sodium concentration, resulting in symptomatic hyponatremia seen with this patient. Symptoms include nausea, headache, vomiting, confusion, and in severe cases, seizure and coma. Treatment for symptomatic acute hyponatremia includes correction of the electrolyte abnormality, either from stopping the free water intake or administration of saline solution. In patients with chronic hyponatremia, there is concern for central pontine myelitis if the sodium concentration is corrected too fast and must be done so slowly over a period of a few days. It's not hyperkalemia will not be likely in this patient. Hyperkalemia can cause muscle weakness, paralysis, cardiac arrhythmia, and GI symptoms. Precipitating events of pathologies include acute and chronic kidney disease, blah, 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 blah. It's not hypoglycemia is a possible cause of symptoms for this patient. Running a marathon will consume a significant amount of calories and does have significant glycemic demands. However, given this patient history of excess water consumption, is most likely hyponatremia. Okay, next.
Okay. A 46-year-old man with thrombocytopenia comes to the office for a preoperative evaluation prior to the extraction of four wisdom teeth. The patient says he feels well. He takes no medication, vital signs are within normal limits, physical examination shows no abnormality, a complete blood count discloses platelet count 1 lakh 10,000. Which of the following is the most appropriate recommendation for this patient?
Normal platelet count is 150, right?
Yes,
It's, hmm, count this. Ready?
yes.
Let's see. Proceed with dental extraction. Thrombocytopenia is characterized by low platelet count, which can result in excessive bleeding and bruising. The most common causes of thrombocytopenia is immune-mediated destruction of platelet, decreased platelet production, and increased platelet consumption. In terms of immune-mediated destruction, conditions such as ITP and drug-induced thrombocytopenia can cause platelet destruction, whereas conditions such as aplastic anemia and leukemia can lead to decreased platelet production. Increased platelet consumption can occur in conditions such as DIC and TTP in this patient with no medical history and using no medications. ITP is most likely the cause. For patients with ITP and stable platelet counts, about 50,000, no intervention for thrombocytopenia required. These patients generally do not have issues with hemostasis during dental procedure. Cancel the dental extraction is not appropriate given this patient has stable thrombocytopenia and platelet greater than 100,000. Okay, next.
Okay. A 26-year-old woman comes to the office. A 26-year-old woman comes to the office because of 12-hour history of product, uh, moderate chest pain and productive moderate chest pain and cough productive of blood tinged sputum. She has no other history of serious illness. Her only medication is oral contraceptive. She took 10-hour airplane flight 2 days ago. She appears be in mild respiratory distress. Her temperature is 37.3 degrees Celsius, pulse 110 per minute, regular respiration are 18 per minute, blood pressure 134 by 94. There is no cyanosis. Cardiopulmonary examination shows no abnormality. There is erythema edema of the right cup. Which of the following is the most appropriate next step? Is it DVT?
It's PE, right?
Hypotension, tachycardia,
I mean,
maybe
the
PEB.
chest pain.
Chest pain,
So,
sorry, yes.
so do we do the D dimer or the CT angiogram?
Most appropriate, CTPA.
Yeah, probably. Okay, let's see. Where is it? Yeah, CT angiogram. Um, this patient presentation of are suggested of PE. Patients classically present with acute chest pain, shortness of breath, hypoxemia. Some patients may also experience unexplained syncope. It's often difficult to distinguish PA from other causes of respiratory disorders. And the differential include asthma exacerbation, vocal cord dysfunction, acute coronary syndrome, panic disorder, vasovagal syncope. The clinician must maintain a high index of suspicion in the use of clinical decision aids like the WEDS criteria is recommended. Risk factors for acute PE include immobility, obesity, recent surgery, malignancy, pregnancy, OCPs, trauma, fracture of long bones, and inherited thrombophilia. ECG often shows normal sinus rhythm and sinus tachycardia. Arterial blood gas analysis typically show acute respiratory alkalosis, hypoxemia, increased air gradient, and as a result of ventilation perfusion mismatch. CT pulmonary angiography is the preferred method to confirm the diagnosis. Serum D-dimer assay is not necessary in this patient who presents with symptoms consistent with PE. This test will add additional evidence that the patient is experiencing a PE or DVT, but does not confirm the diagnosis. And it's not necessary given the high level of suspicion. Mhm. Okay, next.
Next, a 15-year-old boy is brought to the physician by his mother for examination prior to the participation in school sports. He has no history of serious illness, takes no medication. There is strong family history of obesity there, and his mother struggles to keep her weight in the normal range. His father, maternal aunt, and maternal grandmother has type 2 diabetes mellitus. The patient says he eats healthy food, but on questioning, he reports that yesterday he ate 14 ounces of frosted cereal with whole milk for breakfast, a hot dog, potato chips, cookie, fruit cocktail, and soda for lunch, and a candy bar for after snack, and a large fast food cheeseburger, extra large french fry, and a chocolate milkshake for dinner. He watches television, plays video games when he is not in school. He is popular, socially active. He does not have a girlfriend. He is obese, otherwise healthy. He is 160 centimeter tall and weight is 90 kg. BMI is high, 35 kg. Temperature normal, pulse normal, respiration 22, blood pressure 128 by 90. Examination shows moderate acne on the face. Genital and pelvic examination of sexual maturity is rated 4. HbA1c 600, gastric blood glucose 120. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
So he's counseling the patient on the importance of aerobic exercise. In this patient, with a strong family history of type 2 diabetes and increased A1C that puts him at pre-diabetic range, the most appropriate next step is education regarding the appropriate lifestyle modification, including aerobic exercise. Type 2 diabetes is a common disorder in research-rich nations. Initial treatment consists of diet and activity modification, weight loss, and metformin therapy. If these measures fail to achieve adequate blood glucose control, additional oral antiglycemic may be considered. Common options for second-line pharmacotherapy include SGLT, glucagon-like GLP-1 analogs, DPP-4, thiazolidinedione, and sulfonylurea. If diet, exercise, and oral medication do not permit glycemic control, insulin therapy is the next step. Importantly, this patient is in the prediabetic range. He does not yet merit initiation of medical therapy beyond lifestyle modifications, though he should be followed closely for improvement and worsening, as uncontrolled diabetes has consequences including neurologic, ophthalmic, cardiac, vascular, renal, and other complications. It is not E. Hypoglycemic agent therapy refers to medication prescribed to lower the patient blood glucose. These are often referred as okay, and include medications such as metformin, sulfonylurea, blah 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 blah. For this patient with prediabetes and no prior intervention, the most appropriate next step is diet and exercise. Okay, next.
A 72-year-old woman is brought to the physician. A 72-year-old woman brought to the physician by her son a 5-day history of mild left arm pain. She reports that she must be bumped the wall when she was getting off to the toilet. She has mild dyspnea. He has mild dementia, Alzheimer type, rate control, atrial fibrillation. Her only medication is warfarin. He lives with her son. Her two other children live in the same city as the patient and they visit her regularly. The patient's pulse is 84 per minute, irregular. Physical examination show several ecchymosis over the upper extremities and older healing ecchymosis over the forearm. On mental status examination, he has slightly depressed mood and normal effect. He recalls 0 to 3 after 5 minutes and oriented to self and place only. Examination of the upper extremity shows no abnormality. On further questioning, the patient's son says he does not know how she got to the bruises without her son present. The patient is asked if anyone hurt her. She appears uncomfortable and says she is clumsy. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
Mhm. Is contact senior protective services. To protect patients' well-being, physicians have an obligation to investigate evidence of abuse. Physicians should first ask direct, open-ended questions about the physical exam findings indicative of abuse. Physicians should ideally ask these questions to the patient privately without the caregiver present. If the patient denies abuse but the physician possesses enough objective evidence of abuse, the physician should proceed under the assumption that the patient is being abused and report the abuse to the appropriate authority. In this case, is of elderly abuse is senior protective services. Physicians are mandated to by many states to report abuse of children and old people. To the protective agencies then investigate whether abuse has occurred and may remove the adults from dangerous situations. Physicians should treat the immediate symptoms, which may manifest as medical or psych symptoms, and continue to provide regular care to monitor for long-term abuse. Call the patients or the children to inquire about the injuries is unnecessary given the physician's clinical suspicion of abuse. Any suspicion of abuse warrant reporting to protective services, as well as phone call may implicitly communicate to the patient children that the physician suspects abuse. If her children are perpetrating abuse, this may increase the patient risk for future abuse. Okay. Call the police and have them come to the office is premature. First, the physician should notify the senior protective services to initiate investigation and protect the patient from potential dangerous situation. The police may be involved later in the process after patient safety has been addressed. Next.
A 5-year-old boy is brought to the office by his mother for a well child examination. The patient's mother reports that she the patient's mother reports that he has been more fidgety lately and has not been able to focus on his school work for more than a few minutes at a time. For the minutes at a time, he has also does not multitask well. The patient does not otherwise healthy, sleeps well, and has a happy demeanor. He has no history of serious illness, receives no medication, vaccinations are up to date, vital signs are within normal limit, physical examination discloses normal. Which of the following is the most recommended next step in the management?
Do we do genetic testing or do we tell the parents to compare the validated behavioral rating scale? I'll get that one.
Okay.
Okay. So, ask parents and teachers to compare validated behavioral rating scale. ADHD presents with chronic symptoms, hyperactivity, impulsivity, and inattention that occur in more than one setting and impair academic, social, and emotional function. Children with predominant hyperactive symptoms are fidgety and may have difficulty taking turns. This is due to dysregulated dopamine. Whereas children with predominant inattentive symptoms tend to daydream, process information slowly, have difficulty completing tasks. This is due to norepinephrine dysregulation. For diagnosis, physician must establish that the patient is functionally impaired in several settings, so parents and teachers must fill out behavioral rating scales. Stimulants, which include amphetamine, salts, and methylphenidate, are first-line treatment for children aged 6 and older. For children younger than 6, first-line treatment is parent training and behavior management, and stimulants are second line. It is not obtained genetic testing. I was between that. It's not needed for ADHD, though ADHD is heritable with multiple involved genetic variants. It's a clinical diagnosis. Okay, and it's not recommend decreasing sugar intake, though some studies have shown the effectiveness or elimination diets for some children. The effect of diet on ADHD symptoms is not fully known. Okay, next.
Over the past 4 days, an 8-year-old girl had joint pain. First her right knee, then her left knee. She has sore throat 2 weeks ago. What is your diagnosis?
Mm, mm, don't know. Red and swollen tender, and it has a murmur.
I think it's
Mm,
isn't it Jones criteria?
has a sore throat in a
two
murmur.
weeks ago, sore throat,
Yeah.
and migratory polyarthritis. Initia first in the right knee, then in the left knee. I think that's okay.
Yeah. Juvenile, blah blah blah. No, it's not Lyme disease. No. Okay, yeah. Robbie James. Okay, let's see.
Okay,
Yeah. Do you want to read that one?
no.
Okay. Next.
Tell me
Oh,
your diagnosis.
psoriasis, psoriasis. Thank God the person already put it there.
Like there, uh, it is psoriasis, isn't it?
Yeah.
Not because he has given it.
Yeah.
He only got one question right and the rest of the got wrong.
Yeah, this person, yeah.
Okay,
Mm,
let's see.
let's see.
Okay, it's psoriasis. Okay, next.
Let's see. What is the numeric eczema thingy?
Okay, read it that.
What is it?
Nummular eczema is a type of eczema. Eczema is like atopic dermatitis. Atopic dermatitis and eczema is quite similar. Look what they have written nummular eczema and atopic dermatitis variant. So if you know about atopic dermatitis, it is similar to atopic dermatitis. And
So what
nummular
does it look like?
and difference is it is quaint shaped lesion on the extremities. It may be associated with venous stasis and xerosis, but usually atopic dermatitis is associated with asthma. History of asthma or hay fever usually happens in onset in first 2 years of life, like in the babies. You got my point.
Mm-hmm.
But nummular eczema can happen maybe in the older state because due to venous stasis or xerosis is one of the
Okay.
criteria. Okay, he actually listens to you. He read the last line and
Mm.
skip the rest of the line. Okay, which of the following is the most appropriate next step in the management? It 11-year-old boy is brought to the physician because of 2 day history of nasal congestion, mild sore throat. He has coughing and sneezing, productive of green mucus. He has not had fever or ear pain. He has he has pain, no sick contacts. Temperature is 37 degrees Celsius. Pulse is 84 per minute. Regular examination shows clear and mobile tympanic membrane. The tonsils are mildly enlarged. Tonsils are mildly enlarged and erythematous. There is no exudate. There is postnatal drainage in the posterior pharynx and copious yellow-green nasal dishes. The lungs are clear to oscillation. Heart sounds are normal. Which of the following is the most appropriate next step?
Ready? Oh, which one is it?
Okay.
This is a, okay, so it is to provide symptomatic treatment order. Upper respiratory tract infection are common in children and infants. Average children experience up to nine, blah, 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 and children who attend daycare may experience more. These patient symptoms of nasal congestion, cough, sneezing, non-exudative pharyngitis are consistent with viral upper respiratory tract infection. Likelihood of group A staph pharyngitis can be predicted with central criteria based on age, tonsillar exudate, or swelling, lymphadenopathy, fever, absence of cough. Most upper respiratory tract infections are caused by virus and resolved with supportive care. However, specific upper respiratory tract infections such as acute otitis media, bacterial sinusitis, and group A strep benefit from treatment with antibiotics. Okay. This patient has normal mobile tympanic membrane, no fever, no exudative pharyngitis, making acute otitis media sinusitis and strep pharyngitis unlikely, so no antibiotic. It is not the X-ray of the sinuses is not typically helpful as it has poor sensitivity and specificity for detection of allergic rhinitis or sinusitis in comparison to CT scan, which remains the preferred imaging for evaluation of acute bacterial sinusitis. Acute bacterial sinusitis patients typically have prolonged fever, facial pain, and severe nasal congestion, which this patient does not have. Most patients with upper respiratory fever do not require imaging studies. Okay, next. Wait, it's the same question. Okay, no.
Yes.
Okay. Yes.
He got right in the next time. Okay. A 77-year-old man with coronary artery disease comes to the physician for a follow-up examination. He underwent coronary artery bypass graft 4 years ago. Coronary artery bypass graft 4 years ago. He has 3 year history of intermittent claudication. He has 3 year history of intermittent claudication. His blood pressure measurement for his last 8 days. His blood pressure measurement for his last 8 visits show. Okay, last 24 months ago blood pressure was 130 by 80, and last 2 months ago it is 180 by 100. Okay, current medication include aspirin, atorvastatin. Temperature is 36.5, pulse is 80 per minute, blood pressure 180 by 110, which is hypertensive. Urgency, heart sound are normal. Artery dorsal pedis, tibialis, pulses are not palpable bilaterally. Potassium is 3.1, bicarbonate is 2.8, blood urea nitrogen is 20, glucose 90, creatinine 1.1. Which of the following is the most likely cause of these patients' increased blood pressure? Is it aneurysm or artery stenosis?
Abdominal aortic aneurysm dissecting.
Yes.
I think it's stenosis. I don't know why it would be aneurysm. I don't. It doesn't make sense to me. I think it's stenosis.
Why you are thinking renal artery stenosis?
Yeah, why would it be aneurysm? I thought.
Aneurysm cannot come with claudication, isn't it? Arterial
Oh,
can aneurysm come with claudication?
oh, I get what you're saying. Yeah, yeah, it can. I was just mostly looking at the potassium, but you're right that aneurysm can come with medication. Hmm. Okay, let's
I
check.
Okay. Let's see what is the answer.
It's stenosis. It's renal artery stenosis. Renal artery stenosis is a cause of secondary hypertension related to abnormal stimulation of the juxtamedullary apparatus secondary to stenosis of the renal artery, leading to insufficient afferent blood flow. This results in excessive production of renin and angiotensin. Secondary hypertension should be considered in new onset or treatment-resistant hypertension. There are two main causes of renal artery stenosis: fibromuscular dysplasia and atherosclerosis. In younger patients, fibromuscular dysplasia is the most common cause, while older patients develop renal artery stenosis more common from atherosclerosis. This old patient with history of coronary artery disease and peripheral artery disease secondary to atherosclerosis likely has renal artery stenosis. Oh, that was the claudication secondary to atherosclerosis. Diagnosis is established with renal artery Doppler ultrasound of or MRA. Treatment involves angioplasty or stenting of the stenosis artery to improve flow. ACE inhibitors can be given for unilateral stenosis but can lead to acute renal failure in the setting of bilateral renal stenosis. Dissecting abdominal aortic aneurysm is a vascular emergency that will likely present with severe abdominal or back pain, vital signs abnormalities such as hypertension, hypotension, tachycardia, and acute distress are likely. Abdominal aortic aneurysm are more common in male patients, and risk factors include a history of smoking, atherosclerotic disease, and a family history of abdominal aortic aneurysm. This patient is asymptomatic and has chronic history of several months of worsening hypertension, making chronic process like atherosclerosis more likely. Okay, next. You got it? You got why it wasn't like the aneurysm?
Yes.
Okay. Hmm.
What is your diagnosis?
No, no. This the diagnosis. Okay, it's not melanoma. It's not BCC. It's not it's,
Psoriasis. So two things left: actinic keratosis and
it's not.
seborrheic dermatitis.
No, seborrheic dermatitis is the yellow in the hair, so it's probably actinic keratosis.
Yes,
Let's see.
let's see.
I'm liking this.
Okay.
I,
You,
oh,
yes, you are right. So that's how you get confidence.
I'm like
No,
I'm
you
liking.
initially your tendency is not to see the picture.
Mm-hmm.
So why uh, I am just removing your fear and phobia of not looking at the picture. If you can answer just looking at the picture, why wasting time over reading? In the you know the these three BCD option you can easily exclude because you know these things. So
Mm-hmm.
it is not seborrheic dermatitis. Okay,
Okay.
you want to read the explanation?
No, it's fine. We need to finish this. Next.
Okay. A 56-year-old man comes to the office because of 1 month history of non-healing lesion on his tongue. Non-healing lesion on his tongue. He says he thinks the lesion may be. He thinks that the lesion may have appeared when he bit his tongue while sleeping. He has 2 year history of type 2 diabetes mellitus control with metformin and diet. He works as an electrician at a shipyard. He has smoked 1 pack of cigarettes daily for 17 years. He drinks 12 Oz beers weekly. Vital signs are within normal limits. There is 2 centimeter ulcerated lesion over the left aspect of the tongue, and the remainder examination is including head, neck, shows normal. Which of the following is most likely to have prevented the patient's lesion?
Is it HPV or smoking cessation? Oh, smoking. Um, ready?
Okay.
Okay, so smoking cessation. Squamous cell carcinoma is the most common type of oropharyngeal carcinoma. It's strongly associated with tobacco and infection with HPV. Patients may present with a oropharyngeal lump or nodule, non-healing, also dysphagia or dynophagia weight loss. Establishing the diagnosis with the biopsy is essential for guiding future management. Staging can be aided by cervical sentinel lymph node biopsy, cervical sentinel lymph node biopsy, and imaging with CT scan or MRI. Early stage disease may be managed successfully with surgical excision, although more advanced lesions usually require a combined approach with surgery, radiotherapy, and chemo. These factors for oropharyngeal squamous cell carcinoma include tobacco, heavy alcohol consumption, HPV infection. Smoking is the strongest risk factor in this patient history for oropharyngeal thing because he has been smoking for 17 years. These patients should be counseled regarding smoking cessation in addition to previously described workup and treatment. Alcohol abstinence is incorrect. While alcohol consumption is a risk factor for developing oropharyngeal carcinoma, it's not the strongest risk factor as smoking has been primarily shown in patients with a, yeah, he doesn't drink that much. HPV is incorrect. HPV is a risk factor for developing oropharyngeal carcinoma. Um, the HPV vaccine is a recombinant vaccine that is recommended for all children 9 to 12 or for adults who not previously vaccinated prior to age 26. The HPV vaccine first became vaccination in adults older than 26 is controversial and is of possibility. possible limited benefit. Additionally, smoking confers a greater risk of oropharyngeal carcinoma than HPV. So not greater than 26 for the HPV vaccine.
Okay, next. A
Okay.
37-year-old woman comes to the office because of 3-month history of frequent headache. He has no history of serious illness, takes no medication. Her last health maintenance examination 3 years ago does not show abnormality. There is no family history of serious illness. She is 165 centimeter tall and weight is 66 kg. BMI is 24 kg per meter. Her temperature is 37.1. Pulse is 88 per minute. Respiration 16 per minute. Blood pressure 190 by 120 millimeter of mercury. The remainder of the examination showed no abnormality except for an epigastric bulge. Arteriography show fibroscular dysplasia of the renal artery. The underlying mechanism of this patient's condition is most likely initiated by the release of which of the following substance?
Ready?
Yes.
So it's raining. Do I need to read that one?
Sorry?
You want me to read this one?
No.
No, okay.
Uh, okay. A 47-year-old woman comes to the office because of right wrist pain that began 2 days ago when she fell on her hand while playing tennis. She has limited use of her hand wrist since the injury occurred. She otherwise healthy. There is tenderness to palpation of the radial and the dorsal aspect of the right anatomical snap box. Muscle strength of the right fingers 5 by 5. Sensation of the fingers of the hand is intact. Pain extreme of the hand and the wrist show mild degenerative changes at the first carpometacarpal joint. Which of the following is the most appropriate next step in the management?
Hmm. Hmm. I don't know. Ready?
Yes.
So it's cast immobilization. I need to read that one. The scaphoid is a carpal bone located in the lateral wrist. It's the most common carpal bone to be fractured, with the most likely mechanism of injury being a fall onto the outstretched hand. Symptoms of scaphoid fracture include pain localized to the wrist with possible swelling. Physical exam pain can be reproduced with palpation of the scaphoid between the extensor pollicis longus and extensor pollicis brevis, commonly referred as the anatomic snuff box. Scaphoid is at risk for non-union or necrosis with proximal bone fractures, as the blood supply to the scaphoid arrives distally from a branch of the radial artery. X-ray of the most is the most appropriate initial imaging. In cases of negative X-ray with high clinical suspicion of scaphoid fracture, repeat X-ray after 2 to 3 weeks can be performed, as initial imaging may not show the fracture. In such cases, the injury should be preemptively immobilized until repeat imaging can be completed. Treatment for non-displaced scaphoid fractures is generally non-operative with immobilization. In cases of displaced fracture, surgery may be indicated. There is a high suspicion for potential scaphoid fracture in this case, and cast immobilization should be performed until repeat X-ray can be obtained. Reassurance that the pain should subside in 1 week is not appropriate next step management. In this case, the patient had a forward fall onto a stretched hand with pain localized to the anatomic nerve, but there is a high suspicion for an underlying scaphoid fracture. Cast immobilization is needed. Arthrography is an imaging technique utilizing contrast injected into a joint to better visualize intra-articular pathology. Arthrography is commonly performed in shoulder, hip, knee joints to identify conditions such as labral tear as well as tears of the intra-articular ligaments and tendons. In this case, the patient most likely sustained a scaphoid fracture with the most appropriate whatever. Arthroscopy is a surgical procedure to directly visualize a joint. Arthroscopy is commonly performed in the knee and shoulder to evaluate for conditions such as meniscal tear injury or rotator cuff injury because the mechanism of each whatever. Okay, next.
Okay, last question. Which of the following is the most appropriate pharmacotherapy? Spirometry, a peak experiment showed 200 liters per minute and wasn't predicted. In addition to short-acting beta agonist therapy. Okay, okay,
You're
nine.
trying
Sorry,
to you
I
were
think
trying to
that it's asthma, isn't it?
you're trying to answer the question from the last sentence. That's what
Yes,
you're trying
I am
to do.
trying.
Oh Lord. Okay. Read it.
9-year-old boy is brought to the physician by his mother because of 1 month history of intermittent wheezing and mild shortness of breath. The mother reports that his symptoms occur once or twice weekly, occasionally before exercise, and never at night. Exercise. Uh, when his symptoms occur, he must sit and rest. He has no history of serious illness. He receives medication. His brother and sister, younger, has asthma. His parents do not smoke cigarette. Temperature normal. Okay. Blood pressure normal. Pulse oximeter oxygen 99%. Examination show enlarged pale nasal terminate, mildly enlarged tonsil, shorty, cervical lymphadenopathy. Spirometry showed peak spirometer 200 liter per minute, 88% predicted. In addition to short-acting beta agonists, which of the following is the most appropriate therapy?
You still believe it's asthma?
Yes,
Oh,
you are thinking about other. You are changing your answer because of peak expiratory flow rate.
no, the pale turbinates and when the tonsils enlarge and the lymphadenopathy, that's still asthma?
Yes, it can happen. I think so.
Okay. Okay. Let's
And he
see.
has attack symptoms occur once too. Okay,
Oh, yeah, it was asthma.
it is as
Asthma,
is it B answer? Which one?
no, no. E.
C.
It's E. No, it's E. E. No additional pharmacotherapy is indicated, but it's asthma. It says it's asthma. Asthma is characterized by reversible obstruction of the bronchi secondary to hyperactivity and airway inflammation. Okay. Patients present with episodes of
He
wheezing,
has
dry.
not night symptom. That's why they have changed the. His asthma is because of the exercise before doing exercise. Okay.
Mhm. Patient present with episode of wheezing, dry cough, and dyspnea. The management of asthma is dictated by severity level. Levels of asthma severity are intermittent, mild, persistent, moderate to severe, persistent. So intermittent, mild, moderate, and severe. The level of asthma and subsequent the appropriate treatment depends on prevalence and exacerbation of symptoms. Night awakenings and impairment of daily function. This patient has symptoms 1 to 2 times weekly, never has nighttime awakenings, and does not have any reported limitation his daily life. These symptoms, along with strong family history of asthma, make intermittent asthma the most likely diagnosis. Patients with intermittent asthma should be given a rescue inhaler of beta, short-acting beta agonist SABA, but no other treatment is indicated at this time. Hmm. Leukotriene therapy will be appropriate addition to treatment in this patient if he's suffering from mild persistent asthma. Mild persistent asthma is characterized by greater than 2 episodes of symptoms per week, but not on the same day. This is crazy. Night awakenings of 3 or 4 times monthly and use of SABA rescue inhaler more than 2 days weekly. Because this patient has intermittent asthma, any acting, blah blah blah. Low dose steroid and long acting LABA would be appropriate addition to treatment in this patient if he was suffering from moderate persistent asthma. Moderate persistent asthma is characterized by daily episodes, more than one night awakening weekly, and daily use of SABA rescue inhaler. This doesn't make sense. And it's not low dose corticosteroid therapy.
I have
Will
asthma.
you have asthma
Yes, I use inhaler.
and just inhaler or you use any steroid?
Yes, I use salmeterol and fluticasone combination.
So
It's
you
not
use
fake. It's real. That's why I'm sending you picture.
no, I'm saying that this the it's
Like
difficult to
I
understand.
need to use it. Not every day, almost within 2 to 3 days.
But I'm
My
saying that
yes.
for us to understand the way to understand like when is mild, persistent, and what to give when it's like
What happens
not
in
good.
case of me? Like I know my symptoms. If I use like Saba, short-acting bronchodilator,
Mm-hmm.
it never suits me.
Mm-hmm.
Suits me. That means it never calm me. Like
Mm-hmm.
when you have asthma attack, if you use like short-acting, it the Saba salbutamol actually do the bronchoconstriction, but without steroid, you are not able to satisfy if you use mm, like a bronchodilator a lot.
Mm-hmm.
That's the problem actually. Actually, if you are on steroid, that is fine. Sometimes you might have severe attack, then you need the short-acting Saba or salmeterol. You can use that things. And leukotriene therapy, I never use it, but my father actually uses it, and he is pretty good on leukotriene therapy. He
So how
has a
do
sorry.
okay, so do you have a thing for this like okay, this